Donna introduce our special guest today.
Who's that, Dr.
Two of you, two special guests. I'll let you use this. Well, maybe a...
Good afternoon. I want to welcome everyone here today and for our third meeting. And I especially want to welcome Secretary Mitchell. We have been holding our meetings during the middle of the legislative session, and we've been hopeful that we would get to see Secretary Mitchell during this process, since we chose to have our meetings during the busiest time of the year for the Secretary, and we're especially happy to have him here today. I want to give him an opportunity to make some brief comments, and then after that we'll go around and introduce ourselves, and so that we can see who's here or who's on the phone, and continue on with the meeting. And I know that the Secretary has to go back down to the legislature this afternoon, so we'll be grateful for any time that he can spend with us today.
Great, thank you very much, Donna, and it is a pleasure. Steve, I think, has probably asked me 15 times to get out here, so I do apologize, but look forward to hearing some of your conversation. Unfortunately, I have to go back to Annapolis, as Dr. Half probably doesn't, so that's good. But I do want to sit in on a few minutes of your conversation and hear what you have to say. It's as we all know, it's a very important issue to Maryland from an economic development standpoint, and also from the hospital and the payer standpoint. So Donna and I have conversations on a regular basis, or as needed. I try to make myself available to her and to everybody in the room. So with that, I'll just kind of turn it back over, and you can do your introductions, and we'll be more than happy to answer any questions.
Okay, well, maybe we'll just go around the room as we normally do, and also see who's on the phone. And I'm Donna Kinzer.
David Salke from UMBC and Johns Hopkins.
Ben Stephan, Maryland Healthcare Commission.
Vinny DeMarco, Maryland Citizens Health Initiative.
Kerry Simmons, United Healthcare.
Eric Wagner, MedStar Health.
Vince Ancona, Amerigroup.
Gene Ransom, MedKite.
Willarda Edwards, Internal Medicine, Private Practice.
I'm Tom Walsh. I'm a private practice physician as well from Maryland Primary Care.
Jeff Burrell, here first.
Lenny Preston, Maryland Women's Coalition for Healthcare Reform.
I'm Joe Ross. I'm from Mary's Medical Center.
Bob Kremzik, University of Maryland.
Bruce Vladek, Nexera.
Peggy Nalepa from Peninsula Regional Medical Center.
Kevin Sexton from Holy Cross Health.
Izzy First from Lifespan.
Carmela Coyle, Maryland Hospital Association.
And Howard Half, DHMH.
Jack Meyer, Health Management Associates.
Do we have anyone joining us via WebEx? No, so we have no one joining us via WebEx. Well, again, thank you, everyone, for being here today. We'll quickly turn over to Jack to take us through a discussion of a draft interim report and next steps. We've had just a couple of meetings and started the process of envisioning where we're headed in the model, and after the interim report, we expect to continue a process of beginning to drill down further into how we might go about implementing some of the things that we've envisioned. So with that, I'll turn the agenda over to Jack and let him get started in terms of the report.
Good. Thank you, Donna. Thank you, Mr. Secretary, for joining us today, and Howard. full table, so I appreciate everybody's turnout. I thought I would organize the discussion this way with your permission, and that is to start by and give top priority to overarching reactions and comments to the draft interim report. I will save time for specific comments, concerns you might have about a section, or I really don't like paragraph 3 on page 5. We can do that, but I think that, and I'm confident that some of you have some overarching concerns and restructuring that you'd like to see, points omitted, points not stressed enough, and I thought I'd start with that. So if there's no objection, I think we'll proceed along those lines. As always, we will reserve the last 10 or 15 minutes for comments from the public or questions, so I won't forget about that. So would anyone like to begin? Chet.
Hard to disagree with anything this year, except that it's at a very, very high level, which I think was intended, but a lot of the questions that arise from the reading of this are, how is this to be fulfilled, any one of these elements? So the how and the what are begging to be answered here, I think. When we talk about accountability, for example, who is accountable for what? What are the various choices on that accountability? And it's at a very high level, I guess is what I'm saying. And I don't know what the intent is from here, whether that is to make it somewhat more specific without being overly prescriptive, or what, to maybe just ask a question about that.
Well, thank you, Chet. That's exactly what the intent is. We may not have hit it on this first draft, but the intent is to come down from 50,000 feet, but not get down in the weeds. When looking for that balance, we may have stayed up at 30,000 or 20, and I'm certainly receptive for ways to add specificity, you know, subject to not doing a 40-page paper with 75 footnotes. None of us want. But between here and there, there's a lot of room, so thank you for that. Any other comments? Yes, Vince.
So I think it hit a lot of the high points and information that was discussed. But it seems to me what may be missing is sort of the coordination, and maybe that comes from the detail or as you build it out. It seems to me that there's not, and at least I don't understand how all of those pieces and dots connect. You know, while accountability is addressed, it's in sort of silos, if you will, and doesn't seem to be that coordinated approach of how to manage individuals from the well to chronically ill. There's a lot of touch points, and there's a lot related to chronically ill, but those that are kind of falling out of the system, not getting care, you know, how and where is that coordinated?
Good. Okay, thank you. Yeah, Gene.
I just first wanted to say that I appreciate the fact that we got the MACRA and the MIPS in there. I think that's a really big deal for my members that we have alignment, because it would be a really bad situation if we had a bunch of requirements and things that we had to do in Maryland that didn't align with the federal rules that are going to come down in a couple of years, tied with the SGR fix. So that's a good thing. And then I guess I had a question that I bring up maybe fearing the discussion that might follow. We don't kind of reapprove or reauthorize the prior report we did. And the one issue that we haven't talked much, and the reason I haven't brought it up, is because I assumed that we still stand by the language that we kind of agreed to, is the issue of tort and defensive medicine. And as we do more and more of these meetings with my members, they begin to ask questions, well, if we do this or we do that, do we increase our risk of being sued or this coming up? You know, if I'm in an ACO, is someone going to say that you didn't order that test because you were getting shared savings? And I thought the smaller group of us, most of us here, who worked out that language in the first report that was somewhat compromised language, was pretty reasonable compromised language, and at a minimum we should acknowledge that we still support it and and carry it forward, and maybe we should even add it to this report as well, because we put a lot of energy and time, and I don't want to lose the issue because it is a big issue that I think a lot of the folks are concerned about, at least from my community.
Well, good. Thank you, Gene. I put it in because you raised it very carefully at the last meeting, and yeah, macro and MIPS, and it is important, and it is relevant to getting physicians more deeply involved and creating some real incentives for them to address what are otherwise unfunded costs. So I'm glad that you appreciate it. I knew you wanted it in, and I think others will too. I think it's an interesting idea of whether we reapprove the last time report. I'm certainly open to that. You're also right that we spent several drafts on that, couple paragraphs about medical malpractice and defensive medicine. I think we can have a talk about that. That's sort of getting down into the specifics. I'm not forgetting about it.
I understand that, but I mean, and that's why I think it might be easier just to reapprove the prior report. There's nothing in that report that I think anybody would be upset about, and we did spend the time to work out of it. I will tell you, though, that that is an issue that is coming up more and more when we go out, and I do quite a bit of these discussions where I give updates on the waiver or what's going on or what's next for physicians, or talk about Carmela's and my proposed gain sharing programs, and these issues come up, and it's a concern that's there. So I think it's one that we don't want to not address, and since we took the time to work out the language that we could all agree to, I'm fine with just copying and putting it back in, or referencing the first report and saying we still support it, or that's still an issue that's there.
Okay. All right. Thank you. Lenny.
Just to the point of referencing the first report, so that there was an emerging consensus on the consumer engagement in there, and I emailed you about that. So right. I think that was clearly something that was lacking in this report. It could be strengthened.
Yes. Okay. Good. And I did get at your suggestion. I went back this weekend and started taking a look at the report of the consumer engagement work group, which, as you suggested, has a number of recommendations that can feed into this. And I was remiss in not saying at the outset that a few of you sent comments ahead of time. I think I emailed all of you back, but thank you for that. Others bring their comments to the meeting verbally, but I do appreciate the written comments, and they will be addressed. So let's move on. Others? Carmela.
Yeah, sure. Excuse me. If I could pick up on Chet's comment and maybe ask it in a different way, and that is it too soon for this report? and by that I mean, as you take a look at the recommendations, I think it's captured our discussion around focus and data and accountability. But to Chet's point, there's not a lot of meat there yet to those recommendations that we've had a chance to really talk about and sift through. And so maybe it's a question of timing, and maybe this is to you and to Donna both. Is there a reason to push for this report now, or would it be helpful for us to really take this to the next level? And maybe that's a question of who is this intended for and how is it intended to help? We've been clear, I think, around the table on some of these very, very important issues, but I'm not certain we've taken it to the next step to actually give some direction in some cases.
Yeah, good point. Did you want to comment on that, Donna?
Yes, I do. So I do think it's actually important to have an interim report at this point for a number of reasons. But in terms of pursuing directions and starting to pursue specificity, it helps to have an initial framing of what direction you're heading in so that you can tee up the discussions of more specificity and the planning for that in a framework. So going from a higher level strategy to down to down to more implementation strategies, and then in order to effectively have conversations with other participants who aren't in the room, it's really important to have an overall frame of where you're headed so that you can have a conversation of saying, well, we think complex and chronic care, and we want to focus in particular on Medicare patients, and to start with, and as well as expanding that to others, and we want to do ABC. So it's really important to be able to have those conversations so that we can begin to focus the work plan and the developments with others who aren't in the room, and also with work groups who, as we continue working from I'll call it the top down, that we can have work groups working on from other angles to help us with getting ready to drive forward, because it takes a long time to develop some of the pieces that we need to drive the ship forward. So I think it's and also just in terms of our conversations with our colleagues at CMS, that they can understand where we are heading in a general sense, as we then turn to get more specific during the year. But we do have a meeting planned after this one, and the next meeting starts to get into some more details.
I saw Bruce, and then
I'll tee up when you're done.
Oh,
Okay, Joe.
yeah. Let me get Bruce, then Joe, David. Okay, I'm going to make a list. Bruce.
Well, I wanted to circle back to Chet's comments a little bit in two regards. One is we talk, and I think I totally agree about focusing on 800,000 Medicare fee-for-service beneficiaries and improving the quality of their care and the coordination, integration, and so on and so forth. And then the only specific way we talk about doing it is through payment mechanisms. And obviously, this is the Rate Setting Commission, and there's a long track record of being able to use payment mechanisms for a whole variety of ways. But I think we have a lot of experience in the Medicare fee-for-service program that suggests you have to do a lot more than just put payment incentives out there or payment arrangements, and there's no conversation about that at all in this draft. It's sort of supposed to spontaneously happen if you align payment incentives. The other, which I'm sort of skeptical about, the other thing that I'm even more than skeptical about, sort of as the former CMS person in the room, and I told Jack in my comments that this may be a really Machiavellian ploy on the part of the commission. I can't imagine CMS meeting these data requirements in the foreseeable future. And so if you put together a package and say to CMS, we will do X, Y, and Z if you give us the data, you're off the hook. But I think,
that's
again,
the intent we really wanted.
But I think if we want to do something more substantive, then we have to talk a little more realistically about what is really, and that clearly is a conversation to begin having with them. But to start off with this sort of wish list, again, seems to me maybe useful for rhetorical and organizational devices. I don't know how far it gets you in terms of talking about what kind of data you can actually have in 2017 and 2018.
Can you just elaborate on one point, Bruce? Thank you. Do you think that's because they don't have the capacity to do it, or the willingness?
I think it's largely capacity.
Yeah.
So we're getting, the HSCRC is getting claims data from Medicare right now that is current. So we're already getting 100% claims data. It's not identifiable, and we're not yet able to share it with the providers, but we're already getting it. So I want to let you know that things have changed from the production cycle, and we're actually getting regularly produced claims data every single month that is for the last month. So we're not 6 months behind. We're right in line with the production of the claim cycle from CMS these days. So what we're looking to do is to get that claims data turned into data that can be used by the providers for care coordination and doing their job. And we've been working very hard to focus on getting a path to get it there. So we believe we're making good progress.
If you talk to the people who run ACOs, they're been trying to do that too, and there's still a ways to go. I think it's fair to say.
If I could just comment
Yeah.
on that.
Oh, sure, Jen.
We worked for 2.5 years
somewhat different than what Donna just described, because in order to be actionable, it has to be brought down to the patient-specific level.
Yes.
We were able to get that.
Yes.
After 2.5 years of work. And we get it every month, and it's complete.
And that's what we're looking to get, is the same type of data that that CareFirst is getting. And
Independent contractor, we spent a lot of time figuring out how to get it.
so
It does not include drug data. It includes Part A and B data, but no drug data.
So we didn't just start working on it last week. I mean, we actually started working on it last May, and even before, in the focus on getting the data. So we know that it can be done because it's being done, and we need it to implement.
Okay.
So, and I just wanted to
Good.
say.
Well, bottom line, it's doable, but it doesn't come fast. I want to make sure I got everybody. So I have Joe, David, you raised your hand, Vinny, Gary, and Eric. And then I'll come back over side because those are the hands I saw, but I'm not neglecting anybody over here. So Joe, yes, please.
So first of all, thank you for capturing what you captured on this draft report. I think you did a great job in terms of reflecting our previous conversations. Just a couple of general observations. So one, as I shared last time, my sense is that it's all about being clinically driven and aligning payment, right? And I still think there's room for greater specificity in this report in terms of being clinically driven and aligning payment. I think more specifically, the notion of navigation could be beefed up, and I'll send you some language, Jack.
Okay.
And then finally, I don't think we've captured yet in the draft report the upside of hospitals and post-acute care working together systematically in terms of navigating and aligning. I think the language now just reflects that we need to do better with 1 out of 6 unplanned readmissions, but doesn't sort of capture the upside of those partnerships now, and we'll send you some suggested language. But again, I want to end by applauding you and pulling all this together in the way that you did. Good job.
Thank you, and I'd love to see the data,
Yeah.
anything you have.
Yep.
That goes for any of you. Anything you want me to read. I know Lenny sent me a report over the weekend, and if you have anything from a memo to a report to just your own handwritten, I'm always glad to do that. David.
Thank you, Jack. First of all, let me apologize for not having a whole lot of detailed comments. I apologize for having missed a couple of meetings. As I mentioned to Kim, I spent a little bit too much time as a consumer medical care, and fortunately, I don't have any bad stories to tell about that. So I'm glad to be here. I guess I should also add, as an academic here, of course, no one will be surprised that one of my reactions is that we actually need more data. Not less data. And I'm really thinking about the comment that Vincent made earlier on, that when I looked at all of the discussion of data, it really reflected sort of putting together everything that you could get your hands on through the provider process and the insurer process and the process of keeping records and claims, that sort of thing. And one thing that is maybe a longer term concern, and perhaps not even a concern that the council wants to take up, but I think we ought to put out there, is that we ought to, from a sort of public health perspective, also be thinking about looking at the population from the individuals up rather than from the institutions and the insurers down, because there may be lots of things going on out there that will turn out to be relevant that we don't really have as near as I can tell, much of an idea yet as to how to keep track of.
Good point. Thank you. I like the phrase, from the individuals up rather than providers down. Vinny.
Thank you very much, Jack. I join Joe in commending you for the great job on the report. I think it'd be great if there could be some reference to the growing Maryland Faith Community Health Network and its role, especially after my presentation. And I'll send you our Consumer Outreach Task Force report, which describes it. But a quick update is this evening, the Baltimore City Council is going to pass a resolution officially supporting the Faith Community Health Network and endorsing it. And I have copies of that resolution, and there's actually going to be at 4 o'clock. And on back of that resolution, there's a press conference by the sponsor of the resolution, Councilwoman Sharon Middleton, going to hold a press conference with us, LifeBridge folks, and key faith leaders announcing that this resolution is going to pass of supporting the Faith Community Health Network. And we've made a lot of progress since the last meeting where I made the presentation. So I would just hope that there be some reference to that as a building way to make a health system transformation work.
Well, good. I thought I had a paragraph in there.
I missed it.
Oh, yeah. There is a reference on page 6 because...
Well, that's my fault.
No, that's all right. But, you know, it may be that I need to say...
And I read this carefully. I'm sorry.
That's all right. No problem. But if you think I haven't captured it, if you want to add please add this point, I'll do it.
I will do that.
Yeah, okay.
Thank you very much.
Yeah, sure. Gary.
Well, I withdraw my objection.
Oh.
Thank you very much.
Sure.
Yeah, I'm so good I didn't know.
From my perspective, great job on getting it to readable document from all the comments you've had. I think, following up what Chet has said and a couple of the colleagues here, back at United, if it moves, we measure it. So I think here I've kind of lost track a little bit where we're trying to get to. So to have an outline format, pro forma of where we're going and how we're going to measure this and the performance expected, I think that would help us all if we had a little bit of a pro forma in here. Again, reminding what the commitment is and where we're trying to get to. And I think that keeps us on task a little better if we had this embedded here on the pro forma, so we could kind of keep this in focus. Where are we trying to get to with this next component of the waiver? I think that needs to be added here. The other thing a lot of references to Medicare data, but hopefully as a secondary, the population before they turn Medicare, and making sure that we're not losing sight of that and working on getting that data, because in the long run, if we're going to start changing population health, we need to start there before it gets to Medicare. So I'd re-emphasize that someplace more in this report.
Thank you, Gary. As you were talking, I was reminiscing in my mind that I think you gave us the same advice 2 years ago, and I followed it then, and I need to do a better job of following it now. So I appreciate you doing that, and you're absolutely right. Some recent reports, including the one by, I think, Professor Angus Deaton, focusing on the sort of 50 to 64-year-old population and how there's been a deterioration in their health, at least in some subgroups of that. And what that portends is a piece of evidence, among others, that we need to do that. So thank you. Kevin.
Like Gene, I pulled out the first report and read it, and I have to say that although there's an awful lot of good in here, I just think that if the test is how good a guide is this to what we're going to do next after it's over, the first report is much stronger. It's more precise. It's broken into sections, and it has sub-elements under it. And frankly, the fact that we had some significant debate kind of is my test as to whether we got to anything that was meaningful enough. And I think we're short of that right now. I think, frankly, you could all be for this, and the report could look like this, or like this, or like this, or like this, and it would all find its way back to this document as proof that it's okay. And I think that is, frankly, a shortcoming. I would have preferred we went to chapter headers. Here's 3 or 4 or 5 big areas. Here's the things. Here's the issues. Priority. So relative importance and sort of the key cut to the chase issues. I think, given that at least one of the things that's looming is the application that's due back to CMS. I mean, there are some fundamental issues, such as, are we covering everybody? Or are we covering just Medicare that are not addressed? They were addressed. I think Steve Jenks brought it up at a from the in the comments at the end of one of these discussions, but it's silent here, and maybe that's what Gary's getting at. I'm not sure, but I think these are big issues, and I think prioritization is just not quite here. I don't think there's I don't think how much we're going to how much I think it's worth investing upstream, into issues like tobacco and obesity. I mean, I think we should be trying to give more guidance and the relative amount of emphasis we would suggest be placed on this. We're an advisory committee. The commission is going to do what the commission is going to do, but I think we would be shortchanging it if we left it this vague.
Okay, thank you. Eric. Oh, I missed Eric.
He didn't miss me.
I had you on my list too.
I didn't ahead of Eric.
He saw Kevin.
My life's ambition.
It's my fault. I apologize.
Thank you. Thank you, Jack. And thank you for the report, Jack. I'm hearing a little bit of a common thread that Chet started it out. I think Carmela touched on it, Gary touched on it, Kevin touched on it. It is this issue of specificity, and I've said this before. I think that words are important, and if you can drive a truck through the words and do kind of whatever you want to do, then we haven't actually given much of a recommendation. There's a lot of diverse opinions around this table, and I suspect that it would be very difficult to get to a spot where we all agree on exactly what recommendations come out of this group. And I think I agree with Kevin that that's okay if there's disagreement, because that would indicate that we've debated the issue and we've come to a spot. And I think that really ties back, as I heard Chet talking, to what he said as well. I would give you maybe three places in the report, again, without getting into editing different paragraphs. I was pleased to see that you've touched on a lot of the discussion that we've had and the points that have been made. But I do think that there should be more acknowledgement of the private sector initiatives. And I say that in two ways. One is just at a basic, what is the status quo? On page 2 of the document, you allude to the 800,000 Medicare fee-for-service beneficiaries in the state. But the reality is that we now have, and I think I've heard Peggy quote the number 29 ACOs in the state. And I'm not sure what the enrollment is with them, but I would guess that it's, or the attribution is to them, but I would guess that it's a pretty considerable number. And we ought to acknowledge that as we're setting the context for the recommendation, the principles that we're presenting here. I mean, if it turns out that a half of the 800,000 are somehow covered by an ACO, it changes the dynamic of what it is that we're trying to accomplish through these recommendations. And the other place I think that the private sector comes in is in the final recommendation that you've got on page 12 about alignment, which really gets into incentives. And I think it was Bruce who said it's not all about the payment models and the incentives. I absolutely agree. I think sometimes we overemphasize how much time we spend thinking about how to change how different people are paid as opposed to using other tools for alignment. And here again, you could make a reference to the fact that these ACOs are out there, all of which, in order to get approved by CMS, had to talk about how they're engaging physicians in that process and providing incentives for physicians. So I think that needs to find its way there. Second major thing that I would focus on, we seem to have equated medical homes for patients and that patient centricity element with primary care physicians. I don't think the two are equal. I think primary care physicians are hugely important, and so don't take this as saying anything but that. But patients who are in the end stage of their life, your cancer patients, among others, but congestive heart failure patients, they may not need to have their medical home based with a primary care practice. It may be an oncologist, it may be a pulmonologist, maybe a cardiologist. I think we have to make sure the words are open to that possibility. And I've seen some very effective models that actually use those subspecialties in a significant role as a medical home. So let me stop. I was going to touch on the incentives again, but I think I've already commented on
Okay, thanks. All good points. I've tried to capture them. My colleague, Megan Kirkpatrick, who's in the room, is also taking notes. Hers will undoubtedly be better than mine. Izzy.
Yeah, hi. I want to say that we support Joe's comments about clinical-driven and incentivizing along those lines. We obviously support the direction addressing the high risk, high cost, 800,000 folks first. I think there should be more emphasis around data. We have a long way to go in long-term care and post-acute care to get to a place where there's timely, accurate data and systems and connectivity. And I don't think we can underestimate how long it may take to get there. And then finally, I think there should be greater emphasis around behavioral health and cognitive impairment. The population that we're talking about has some significant issues often around cognitive impairment, behavioral health. So aligning those services and supports will be very important. It's not just the patients, it's the caregivers also who often are suffering and may need some additional support at home. So I think there's greater emphasis around that.
Okay, thank you, Lizzie. Ben.
So, 2 points. One thing, sort of, somewhat different perspective. The call out on behavioral health was really one specific domain that you called out. I thought that that's appropriate, but we ought to think about some of the other areas in which there was discussion: public health, primary care. I think people hit on a couple of areas.
Hey, Ben, here as well. There's no one on the line though, so that would be important. The second point I had was I really find that just referencing data is not enough, or trying to focus on only getting it. There have to be tools that can access it and deliver it to providers effectively. And I think we miss the point by just simply getting information. That we really have to have tools appropriately user-friendly and appropriate in order for us to take advantage of data. I think that's I don't know if you use it in terms of information, but I think of data as simply the files that Chet talked about on his flash drive. That getting it is an important first step, but it's not adequate. The last point, I guess, on the recommendations, there's a lack of concreteness throughout those recommendations, but particularly as it relates to focus, which is, I think, sort of interesting, because we really want to have people walk away from focus and say, where are we going? What can I do? How can I help? What's in it for me? I think there's not any sense of any of that in the recommendations yet, and I would like to think that we could tear off those recommendations and give them to a variety of people and have a better sense of where we're going.
Yeah, so on that last point, and see if I got this right, you're saying go beyond saying we need to select a few key challenges and not scatter too thin, to say, and here are the areas we'd like to focus on, and maybe in
I think you get greater clarity even if you don't get universal agreement.
Yeah. Okay. Thank you. All 3 good points. Peggy.
Thank you. Several of the items and content have already been discussed, but I do want to ask 2 questions. One is on the vision statement. This effort should be led by leaders in the Maryland healthcare system. Certainly support that. The state should play the important role of a facilitator with innovations emerging from the private sector initiatives. I'm not sure I have a word picture for that. In the document, what are we saying? Are we saying that we're going to be able to do demonstration projects? perhaps in phase 2 with private sector? Can we be more illustrative in how we're describing what that vision statement means? And because it feels very regulatory at this process in terms of how we've managed the phase 1. And so 2, the second question is, there was some discussion, and I don't know that it's a deep dive in the content of this, but I just don't want it to be lost, that we're going to have to deal with capacity issues and excess capacity, and in a thoughtful way with a methodical approach. When we implement a lot of the measures that we're currently implementing, we know there is excess bed capacity across the state. And so is that managed through a legislative process, or is that managed through a given entity? But I don't want to lose sight of the reality that as we reduce readmissions, as we reduce length of stay, et cetera, we're going to contract even more across the state with our bed capacity. And so we're silent on that from an advisory perspective.
And thank you, Peggy, do you observe what, I'm hearing, but most of you know more about this factually than I do, about a shift of bed capacity from inpatient to the community?
Well, there's a shift in the utilization pattern.
Yeah.
There's a shift. Yes, there is. There's been noted that there's 1,000 excess beds in the Baltimore County city region. We've heard different numbers that are out there. We've heard the tension around the discussion with trying to take a inpatient facility and turn it into a limited capacity, what would be called a critical access hospital in other states. So we need to address it, and we need to have the tools to be able to manage the process. I just didn't want the discussion to be not at least acknowledged from an advisory. Not that we have the solutions, but certainly from an advisory committee perspective.
Thank you. And I know this is an area of Ben's expertise. And you don't have to comment. I'm not putting you on the spot, but his staff is working on this every day of the year. So it is an important issue. And excellent health economists like David have written on this way back. I read your book on it. It's somewhere on my bookshelf still. So it's an important issue.
All three, I just would add all three sort of prongs of that challenge are being worked on, currently in Maryland, not without significant amount of resistance.
Good. Yeah, well, it's an important issue. We had not addressed it in this draft, certainly, and if you have some specifics you think of or would like to make sure,
Well, just that the advisory committee recognizes that as we deal with population health and the quality mandate, that contraction will occur. It is a reality. We've seen it across the state, and readmissions are reduced. So we need to plan for that.
Okay, thank you. Chet.
Maybe just one follow-up, but I agree with a lot of what was said, Eric, Kevin, Carmela, and others. Just maybe one question, observation that goes back to something I had said in the first meeting. Sorry.
My fingers all over the
I keep finding in my own case, falling back on the question, who is accountable and what are they accountable for? So I assume for a moment, I think we all do, that it will not be comfortable to go to a test of a Part A and B combined, that the limits that the state will be subject to will be stringent. I assume they're not going to be easy. And so the question arises, what happens when those are not met? And more specifically, who is accountable when they are not met? So, for example, if we were to, as a state, supposed to achieve, for argument's sake, a 2% growth in A and B per capita combined, and we were at 2.5, who exactly is accountable for that, and who takes the pain associated from that? Is that the hospitals? Doesn't seem fair entirely. Depends on how it's set up. is that an ACO? Are the ACOs really prepared to take meaningful risk? Is it some combination? Is it a PCMH and they're going to take risk? I mean, I find myself struggling with the question, if you don't know the answer to that, how do you answer any of these other things? Not that necessarily the advisory council should be answering that way down deep in detail, but it perhaps, I think Kevin and Eric was saying this, and Carmela, there has to be some guidance on it, I think, or there is no routing here of what to do, what we're advising on. And I think that's among the toughest of the questions. Today, if in a global budget revenue model, if the hospitals exceed the global budget revenue, they have a consequence. But here, it's taking on all the other costs that are embedded in the community. How do they do that? And is it just them? Or is it a combination of parties? And if it's a combination of parties, how do you deal with all of that? And if we don't have perspective on that, it's hard to answer how you would deal with each one of the specific parts of what has been raised here, at least as I see it. So that raises, that would be the observation, I guess, or the set of questions that come to mind. But the other is, if this is an interim report, I just want to make sure we all understand, is this report as an interim going to be further developed and have as a second or final version, or second and third and final version, I don't know how many there are, as we move more towards specificity, a greater level of specificity as we go, so that it goes, as you said, from a very general statement of vision and all of the main parts to more specificity? How are we, I guess, to understand the progression of this?
I'm going to get that answered for you. I think probably Donna would be better positioned than I would. But let me ask you a follow-up question. It's an interesting point that you've raised. Do you think the flip side of your hypothetical example is pertinent also? Suppose the cap is 2% and it comes in at 1.5 instead of 2.5.
Very pertinent.
Then how are the gains distributed? I see this in other states. It's a big battle in New York over DSRIP and other states. You know, if we do this for you, who gets it? And you know, so you agree that it's.
I agree. It's both ways. It's not
risk and reward.
I worry more about the
yes.
risk. It does more harm.
Yeah.
But yes, it would go, I think, both ways. If there is gain, how is it shared? With whom is it shared? And how does that relate to the accountability of who produced it?
Right.
Which is where most of the dispute comes in, when it's not so easy to decide who actually produced the result. Failure to answer those questions leaves you sort of at sea with, well, how should we design it? And what advice should we give as an advisory committee or council? So I was wondering whether this moves from where it is to a greater level of specificity on those kinds of issues. Not all the way down to the mechanics necessarily, but greater specificity than where it is right now.
So I think, you know, to Kevin's earlier point, when the advisory council came together the first time, we were in the process of implementing a model that had already been approved. So now we're actually trying to start by envisioning where we're heading and to set a frame for that. And then we do need to put more details in place, but we are actually starting at a different point, more like where we would have started at when we were doing the application for phase 1, to say, well, here's the general framework, and if you look in our application, there's a vision that's laid out in the original application. But there weren't a lot of implementation details. There were some. So I think now we're trying to start at that high level and then start drilling down into providing some more detailed framework. And hopefully we can start doing that at the next meeting, and we can update the report. But at least we've got the first framework, hopefully, that we're starting with that will help us bring back the right things to the next meetings. But I do want to point out that we're not at the implementation stage. We're at the vision stage.
I'm really not even touching.
And then we need to get in a bit more into the how and what. So I think that is a valid issue that needs to help us drive forward the process for the rest of the year.
I'll just make one other comment and then be quiet. But I agree. This is not, and I didn't intend anything I said to be at an implementation level or anything else, but to go very, very general like this as guidance, then to very, very specific through the HSCRC or some other mechanism, combination of mechanisms, leaves a big gulf in the middle where all the action really is. And I think if we are to render meaningful advice, I think we have to get into that middle space is all I'm saying.
Right. I think we have a meeting scheduled in April. So I think we're wanting to start into the middle space somewhat to add more clarity to where we're headed and to start to put more meat on the bone, so to speak. But
that was my question.
So thank you. That leads. I'm listening. I'm hearing a common theme across 4, 5, 6 of you, starting with Kevin and Eric, and Chad has built on that, and some others, for more of a sense of priorities, sense of specificity without getting into the weeds of this, and less big think and more direction, specific direction. So I'd be open to hearing advice or examples of how that can be done. I think what Donna is saying is, yes, there'll be a follow-up report from this group. And I didn't mean to leave out Carmela's point, too, about the pace of this and are we going too fast and all that. So help me think through what we could do to capture your concerns to wrap up this report and have it be more that you would feel it was more helpful than you feel it is now, while saving some things on the to-do list for the next couple of meetings. Carmela.
And also, I don't want my thought to be taken to be we're moving too fast. I actually think the report is moving as fast as we're moving, but we've only had 3 meetings and we haven't really dug in yet. My suggestion, I think if you look at the recommendations, they talk about the what's but not the how. So for example, focus. We've said focus is important. But I think it would be important for us to have a conversation to say, what does focus mean? And perhaps we could identify 3 or 4 things that this group, because here's the good news. You've got all the right people around the table. And the other good news is everybody seems willing to dig in. So what does focus mean? Accountability. We've said that's the what, but how? What do we mean by that? In reference to payment mechanisms, is it more than payment mechanisms? Are there other ways? Data. We've said that's going to be critically important. That's the what, but what's the how? And what does that mean if we can't get access to that data for some period of time? What are the implications for what we do in the interim? So it's all, in my head, it's almost taking each one of these current recommendations and digging down to the next level. I'm very cognizant of, Chet, to your and Donna's point, this isn't the implementation group, but some of us were in that gulf last time around, and there's a lot of ideas to be exchanged. And then if I can flip that, so on page 8, for example, we talk about the importance of regional collaboration, which I don't disagree with, but we haven't really dug in. So what does that mean? Why do we think that's important? What else would be on that list of importance? It just feels like, to me, that we're a couple of meetings yet away from really providing some direction.
Okay, David.
Sorry to be late. We had a miraculous spring snowstorm in Boston, but also miraculously Southwest got out. So a lot of the I apologize if some of the comments that I want to make have already been made. I would echo some. The idea of getting a better picture of what would be success in terms of the middle ground would be, I think, helpful. to this report, and there are a couple of specific areas. I don't know if you've talked about MACRA around the table that you have already.
Just briefly, but it needs expanding. Gene raised it. Only thank you for putting something in there.
Right.
But the floor is open for you to comment on
So
that.
I think emphasizing much more directly the importance of negotiating with CMS an arrangement around MACRA and how the state's participation in the waiver or the positions physicians in the state with respect to MACRA, whether if they are part of the state's arrangement, they are therefore part of an alternative payment mechanism, or if they're not, how the payment arrangements in this new regime will align with the MIPS incentives. So I think it's a big elephant in the room, and one that, especially if you're focusing on Medicare patients, needs to be one of those areas where there's more. Maybe that's an implementation detail. I'm not sure, but the emphasis on its importance didn't come through in the report, it seemed to me. The other, this is a prodigious exercise you're undertaking. It's certainly from all the way from Massachusetts. It looks like a big deal, and trying to get the incentives that you create, and by incentives I don't mean just financial incentives. I mean influences on behavior that you create at the level of the state to penetrate down to the level of frontline providers, where the rubber really hits the road, is a huge problem, not just for Maryland, but for every organization that's trying to change the behavior of its providers. And you're trying to do this on multiple levels through multiple organizations, some of which haven't been created yet. And the regional collaboratives, from that standpoint, draw a lot of attention. So I guess the question is, how do you know when you've been successful and in creating those layered incentives? And one test might be that when it's easy for providers to do the right thing, when all the incentives that they face, all the influences on them, encourage them to to participate in what is known to be best practice, to do things that are societally beneficial for patients, that might be a test that you could apply to understanding whether you've actually got it right around the incentives. From that standpoint, I think there was insufficient emphasis in the report on the use of data to influence provider behavior. So it's not just about categorizing patients, which is very important and something that needs a good deal of work from a technical standpoint to be successful. That is categorizing patients as to their needs and as to the appropriate, creating the ability to allocate resources appropriately for the patient's needs. But also the use of data for providers to compare their behavior and performance to other providers, which is a very powerful non-financial incentive, in some ways more powerful than financial incentives. So, and thinking in general about the way in which your new regime can create peer influences that reinforce the financial influences that you're trying to create, I think is another theme that is worth emphasizing as a criterion of judgment. Do we have it right? Well, have we created incentives for the kinds of behaviors we want to encourage?
Yeah, thanks. That's a great point. I remember early on when I got into healthcare, physicians telling me that, and employers that were working with providers through their business coalitions and all this stuff, which is more important then than it is now. CMS was less active. Employers were more active. And they were saying that when the medical director sits down with the doctor and says, here's a scatter diagram, and here's your dot, and it's down here, and this is me talking to you as a physician to a physician, your buddies are up here, and let's talk about what you could do and how we could help you get to up here. That most physicians say, oh my God, A, I didn't know I was there, and B, how can I get there? They weren't recalcitrant, maybe a few, but they just didn't know. And using the data in a non-confrontational way, but to bring them along, it's a very good point. Appreciate a comment on that.
Well, this sort of brings together a bunch of different things I think people have been saying to me, really starting with Chet, because assuming we want to make sure that doctors have the incentives to do the right thing, they're not just financial incentives. I still don't know who the we is in many of these cases. I don't know how those physicians are going to be organized, or who's going to be responsible for getting that data, or who's going to be responsible for defining what the best practices are, or who's going to be responsible for worrying about the question of accountability about dollars, whether it's on the upside or the downside. If they're all signed up so that 100% of their practices is in shared risk arrangements, that's one thing. But if we succeed at David's excellent succession and get CMS just to say, well, every physician in Maryland is in an alternate payment plan, and so we don't have to worry about the incentives, but then there's got to be somebody running that, or at least running the back office of that. And I don't know who that is. I don't know if that's the commission's role in an expanded waiver. And then I don't know how, again, back to accountability, the doctors and the hospitals are supposed to relate to one another. In some cases, it's easy. They'll be employees. In other cases, it'll be impossible because they'll be faculty. And then there'll be a lot of parts of the state in which there'll still be independent voluntary medical staff. And so the institutional framework in which all of these good things are supposed to happen is not, I don't suspect, likely to arise spontaneously. And so we're going to have to say some things about how to at least create a framework in which it can develop so that all these things we think people ought to be doing actually can be done by somebody who has a legitimate role in doing it.
Yeah, that's a good point.
And I don't know if that's preliminary or secondary.
No, we can worry about that later.
But sooner or later, we got to figure that out, how this thing actually works.
Yeah. We actually say in here that we can build on the excellent hospital level accountability to bring physicians, other clinicians, et cetera, into accountability partnerships. And I'm actually surprised more people haven't said, whoa, what's that? Everybody around this table who was at a hospital gets it. It's you get this much money. That's it. So if are we talking about global budgets beyond that? It certainly raises the specter of something on that continuum. And I didn't think it was saying that was the case, but I do think trying to come up with a construct as to how you would phase this, or how you would decide where on the continuum people ought to be, and to get at comment earlier is, well, you know, who is responsible for this and who gets the rewards? Well, from a really parochial standpoint, if you're absolutely on the hook for the downside, you should absolutely be on the and if you're in the mushy middle, maybe you get some and don't get all. I mean, we're going to need to make spectrum. We're going to need to have at least a philosophy. I mean, that's still pretty high, but it is a philosophy that we would have to espouse somewhere on there. And I don't know whether we would be able to get to that or not, but I think that is. I think you'd have to raise do we have enough money in the post-acute area, just in terms of our pie chart, to get done the things we're expecting people to do to keep people, you know, the sick people out of hospitals. I think it's a real question. Where it's coming from, I guess, you know, we said in the original report, well, some of it should come from outside of the pure rate-setting pie. We should have other sources of revenue. I don't know if that means we should get the Medicaid program to raise their rates to, you know, to the long-term care end of the spectrum. I don't know, but I mean, I think you do pretty quickly get into some areas where you're going to have to at least set a construct for how to, or I don't think we'll
we'll get very far.
I think I know what Izzy's answer might be to your question.
Whispering to him, yeah.
You set me up.
No, I read the same sentence, and I agree. The way I read it is that it would be more moving everybody toward more a global budget. Unless the financial incentives are aligned, it's not going to work.
So
financial incentives are aligned is not so easy.
Yeah.
Because
that's back to David's point about behavior modification. You don't just
anybody who's worked with the medical staff on trying to deal with those issues knows that even if you're talking about, again, everybody's sharing in a common pot in one way or another, the internists are going to complain their surgeons are taking too much. You need a mechanism for resolving that one kind or another.
Yeah.
Maybe the word we're kind of dancing around is governance. You have accountability there, you have collaboration, you have a lot of functions of governance, but you don't actually call out the need for some structure. Not that anyone wants to be associated with anything that sounds like bureaucracy, but you do need a way for people who participate to have a voice and to then come together with more than just voluntary collaboration.
Yeah.
And,
well, I'm sorry. So I think, Carmela, you're onto something, and I don't know if we can finish it today, but you seem to be saying in your last set of remarks that maybe we could take some of these areas like focus and accountability, starting right now, and, we may not finish this, and in response to the concerns I've heard expressed around the table, try to go down to the next level, 40,000 feet to 20 or whatever it is. And as some, for examples, well, you could start with focus. If we had 3 or 4, what could we say beyond saying you really ought to pick 3 or 4 things, which is what's there now, and don't, try to cover the whole waterfront? What would those 3 or 4 things be? And, what things do need to be built, picking up on the discussion that David and Bruce were having. We don't have unlimited resources, but what might be, and I think getting back to Kevin's report, a note about the first report, I think we did that to some extent in the first report, and you're right, Kevin, we may have had a little more specificity then than we have now, ironically, but does anybody have any comments about that, of how that section, just taking that section, Chet and Gary?
Well, just a thought to build again on what Carmela said. I think Kevin as well. If you took, if it is the general sense of the group, Jack, at a high level, was well done. If we were all to go back, we would certainly be prepared to do this and say what specific ideas, what specific issues, and what specific questions needed to be answered in each one of those topics. The focus and the accountability and the alignment and so on. If we were all to do that on our own, perhaps feed them into you, there may be, what comes out of that is a commonality, and maybe not. Yeah. But either way, you learn something that then would form the basis, if that would be shared with the whole group by the time we get back together, that seeks the middle ground. Doesn't take it all the way down, but gives it greater framework than it has today. And speaking for us, at least for one, I'd like to have the opportunity to give that some thought. But I'd like to suggest that perhaps as a next step.
Okay, how do others feel? And could we get started on that today? I hear what you're saying, because we're not going to go through it all in an hour, or we don't even have an hour, 40 minutes. But so I hear what you're saying. How do others feel about Chet's suggestion? Joe.
We'll
get green eventually. There you go. I think there's power in that suggestion. I think if you look at the collective insight, experience, and commitment to moving the ball forward around this table, I think we could accomplish a great deal by that approach. You know, maybe get it started with it now, but it's very substantive. So to the extent that we can talk, you know, get more specific about those issues that we talked about, you know, navigation, clinically driven, you know, more specific on all of that. How do you share the upside? How do you share the downside? So I would endorse Chet's approach. I think when you look around the table, there's a lot of power to be had by tapping this insight in a more sort of way of depth going forward. Yeah, I like it.
Okay. Gary and then Eric.
I'm still struggling a little bit. You know, a lot of what we're doing is trying to make the affordability, the economic commitment Maryland has made. I still need to see that. I think, you know, from where we are to where we're trying to get to, and one of the functions of this advisory council is to make sure we're continuing to improve quality of care, and we don't lose sight of that. So being able to have, you know, from where we are economically to where we're trying to get to, and then I think back to what Chet was talking about, the components individually, that we don't lose sight, that we provide guidance and help and break it down into those categories to, you know, to provide input. But I'm still here, I'm still at the end of the day, and back where Chet was saying who's accountable, but I'm still struggling a little bit. Where are we, and where are we trying to get to in the commitment that we made to CMS? I think that needs to be more visible so we can continue to provide input that quality care continues to go up, and doing all the right things that we need to have and available, and things that we're not doing, then we can comment on that. I'm still struggling for that.
I like Chet's idea. I think I'd be very hesitant to dive into it here today and just kind of you know, blue sky it. We each carry some things around, but as I mentioned earlier, I think we're missing even some basic facts, like how many of these 800,000 Medicare beneficiaries are in some sort of an arrangement today. It'd be helpful to us as we're trying to address the questions that Chet has posed. And what I heard was we should each be thinking about some details behind each of these focus areas. I think the second point you made, Chet, the questions that need some answers, I think is of critical importance. I really like the way David kind of grabbed this and said there's a governance piece missing, and I'm going to call it the who, right? So for each of these points, who is it? So who's accountable? Who gets the data? Who's doing the alignment? Who's focusing? Who's deciding where to focus? I mean, that's a piece of that is governance. A piece of that is, you know, there's a lot of us that are trying to do some of that now. And I'm very cautious at the notion that we should put aside those private sector efforts and be focused too much on what, you know, the state itself, the government, would set out to do. I think there's a great learning lab that comes from having 29 different organizations trying different things and seeing what works. And you make that point, I think, in parts of this paper here. But that takes time. You know, it's not just something that we're going to look at after 6 months and say, oh, that was great, let's implement it in the rest of the state. So I think those would be some of the pieces I would supplement what Chet was talking about.
Yeah, and my sense is, Eric, by the way, back to Gary's point, I remember having this metaphor 2 years ago when Gary made his point. I envisioned, I was driving a car, and Gary was saying, you know, are you going 100 miles? And if so, how far have you gone now? And what have you accomplished in the first 20 miles? How far do you have to go? Do you know where you're going? And can you report back after 20 miles that, you know, what you've done? And so I think that is useful. On your point, Eric. I think part of it, and you may want to comment on this, Donna, if you want, or others, there's maybe some usefulness of contrasting and comparing what is being attempted in the all-payer model in terms of care coordination and, really getting sort of systematically consistent data in consistent form and developing care profiles and care plans that are customized to the patient and putting a lot of infrastructure into that. I'm probably not doing justice to it, but a big effort on this fee-for-service Medicare population to identify the high risk, assess their risk, get them these care plans. That's where they seem to be going. And now you have 29 ACOs. I haven't looked at them carefully, but I've looked at them in some other states. My guess is they're probably at very different stages of development that in some cases, while good, may fall well short of that plan. So I agree, you don't want to not pay attention to what you're already building on the ground. That's a good point, but it may be that it's not as exciting as what you want to do, at least in some cases. Does that make sense?
I'm not sure that I agree with the premise that somehow, crafting something that is much more elaborate and on a statewide basis is a priori going to be more successful than a bunch of different ACOs. And I'm not speaking as a huge proponent of ACOs, but it is a reality that a lot of our organizations have established them, and they have all the characteristics that we lay out here. They've got focus, they've got data, they've got accountability, and they've got incentives and alignment. And if any, and they generate a reward for their participants. So if anything, that should be creating a strong focus to get the problem fixed. I think part of it too, and I was just thinking as you were speaking, Jack, that part of it is too is that we're looking for instant gratification. It doesn't work that way.
Yeah.
It doesn't work that way in medicine. I mean, it takes some time after you diagnose the problem and you begin the treatment to see the results emerge. I think it takes even longer cycle times with what we're trying to accomplish. And so we just have to be cautious. If we're looking for results really fast, it's actually going to take a period of time before we get those results.
Yeah. Yeah, and that may get back to your point about timing and the difficulty of doing things and under what period can you do them and what do you do first, second, and third, because you can't do them all at once. So I'm sensing a consensus is emerging around following this plan. I'm also kind of, we have no magic end time, so I'm perfectly willing to do the public comments and bring the meeting to a close and everybody does their homework in a next couple of weeks. But does anybody else want to, Vince, chime in so we get some structure around what might happen? And I want to see how you feel about it.
That's where I was sort of going to head here is the structure, because if you ask us all to go back to deliver something, you're going to get a lot of inconsistency back. So if there was some sort of structure provided that we could, all address in a similar manner, you might get a better outcome.
Yeah, definitely. Yeah.
I agree with that. It's part of the reason I suggested it the way I did, which is assuming everybody agrees on the main blocks that were written, which I thought going around the room sounded like everybody kind of did, how would one develop them? And I think David's point about adding governance is a very good one. But if within each there were specific ideas we each wanted to bring out, important things that we think should be considered, and then issues that relate to that topic that we see, even if you don't have the answer, and then what specific questions within each area we think should be addressed. And then any recommendations that one might make. They would be different, but there may be a healthiness in the difference because it would expose it and it would give people time to think about it. And then if it came in written form, it could be shared, organized, Jack, by you and your team, and then sent back out. and that becomes the agenda for the next meeting, perhaps. Gives us something to chew on, and as opposed to sitting off the top of our head and trying to think about it.
Yeah, I hear you. I hear all of you. I think that makes sense. Kevin?
Maybe we could ask everybody to just list no more than 3 to 5 things, which are the things they think are the most important things for us to include and to ultimately opine on. With the goal being they would be directions, or at least our advice relative to HSCRC actions, other actions within the health sector and the health regulatory sector, and relative to the application that's going to ultimately go into the to CMS.
I think that's helpful, Kevin, because I think now that I'm listening and absorbing as best I can, I was envisioning tasking each of you with giving 3 to 5 things within each category of the report, and that's 18 or
God bless you.
20, and that you know, that's hard. That's too big of a homework assignment, and it may not be productive.
I also think there's a value in everybody going through a bit of a prioritization exercise. And if we do it in 2 weeks, you've got time then to get something turned around. Because I think that's, if we don't get something back that is ahead of time, it's going to be just as tough the next time to deal with it. So I think we have to put some time frames on this and some constraints on it.
What do you think, Damon?
I think that makes sense. There is some background information that at least those of us who are not from inside the state, but I sense that others are also a little uncertain, and that is sort of, there are X number of ACOs, they cover X number of, the X proportion of the Medicare population. The challenge of creating a structure and an infrastructure and aligned incentives and the ability to focus does depend a little bit on what you've got in place. And if an appreciable part of the target population of Medicare patients is already in the jurisdiction, I realize they're not assigned ACOs, but if they're in the jurisdiction of ACOs, if they're utilizing ACOs, then that may be, and that's a whole bunch of things fall out of that with respect to what one needs to do to effectuate this plan. So if you could give us just, if the staff could give us a little bit of background on what we know about existing and structures, also the regional collaborative idea. It sounds like that's pretty new. I don't know how it fits into the work that's going on here. I guess it's part of this initiative, but what is it? What are regional collaboratives? Do they have a governance structure? Do they have rules? Can they be accountable? Are they meaningful? And there are a whole bunch of, maybe this is too much in the weeds, but there's a certain amount of background information, at least for me. Others may have this at the tip of their fingers. But
okay, that information exists. I mean, there's been a lot of work put into the regional collaboratives, and that can be put together. How do you react? Any guidance that you want to, or reaction, if you care to, about the direction we're heading down, over what we're going to do the next couple of weeks, and how that fits into the next meeting?
No, I think it's helpful, helpful to begin to start to lay out how a process of how we're going to move down to the next levels and start filling in some more of the details on in answering some of those questions. So I think the questions definitely need to be answered, and it provides a structure to help the process along.
Okay, good. So what I'm hearing, picking up on Kevin's point and what David has said in chat and others, all of you really, is the homework assignment, so to speak, over the next, and let's keep it to 2 weeks from today, just so that our team as a whole can absorb it, organize it, rewrite it, which takes a little time, more than a little time. What you'll do is identify the 3 or 4 key priority things that you think need to be done that haven't been done, to breathe life into the topics of accountability, alignment, action steps, maybe that's too strong a word, but priorities certainly. And following David's idea, at a high level, governance responsibility, at Chet's point, accountability, what are the consequences of wins and losses, and corrective actions, you know, how does that work out? And so I don't want to put too much structure to it, but I'm hearing that you think if things are too vague, too general, need more priority specificities. Say what you think the most important ones are. I'll leave it to you as how to, they don't all have to follow a cookie cutter structure, but it'll be our job to assemble them and kind of redo the document around them. Are people comfortable with that? Or if I haven't said it quite right, Ruth?
I would be more comfortable, bad student that I am, if the principal would, in the next day or two, just try to put it on one page, because and with lots of, a lot of it will be open-ended, but just because every note I have has a slightly different list of things to worry about in this process.
Yeah.
So if you would try to, even just your own view of what the sort of 3 or 4 things are that we want to focus on, plus anything else people want to talk about, that would be helpful to me, and I think it would be helpful for you when you get the comments back.
Okay. Well. You're always a good student. You won't get detention. I can
just write it on the blackboard.
Yeah. Joe.
It seems to me the other piece of this puzzle is, given the diversity of the background that should be added to the list, is what are the struggles with this now? So governance was an example of one that was raised, but in terms of what are the struggles around data? What are the struggles around certain kinds of social conditions that might be unique to a community? And sort of what are the questions as a community or as a segment have you struggled with and haven't been able to answer? You know, we've been on a global budget in a fairly defined geographic area for a long time, and we've got some real hurdles that we've just not figured out, even at a strategy level, nonetheless an outcome level. And I think those would be definitional and helpful as well, and particularly if they're presented as questions that can become discussion points. And you know, some of it may be academic input, some of it may be experiential or from other markets and communities. But you know, there are some real big rocks in the road as you actually try to do this work, and I think those ought to be here as well.
And Joe, I don't mean to take your point and make a left turn, but I was thinking, I think about very much the same thing. Rather than struggles, I was thinking about the uniqueness that we have in Maryland that forces us to maybe wrestle with these things differently. Just a couple of things I was chewing on. You know, we talk about ACOs, but in the other 49 states, when they talk about ACOs, they're really looking at it for the Medicare population, and they've got this other book of business to be able to potentially wash out the performance within that ACO based on a fee-for-service volume, you know, model. We don't have the ability to do that. So when we talk about structure or governance, it's for all patients. Similarly, on the data side, when they're experimenting in the other 49 states, they get the Medicare data because it's for the Medicare population. We're going to continue to have a challenge to have data across all payers to inform what we're doing. I just wonder if there aren't some of these sort of unique issues that we just have to think about, because it's still, I think, an important reminder that we're way out on a limb already in terms of what we're doing in Maryland.
So, I mean, I will agree to prepare that one-pager, but I would also encourage you not to be locked into it. It's a guide, and I know you meant it that way, Bruce, and then you can, it'll lend a bit of structure to it, but you don't have to follow it perfectly. And you can add something, you know, or something like that, but you're probably right. That probably would help a little.
Just a quick process question. Are you going to take our inputs from today and provide another draft of this, and then we work off of that draft, or do you want us to work off of this draft?
Well, what I see happening, that's a good question. What I see happening, to do justice to what has been outlined here, is hopefully by close of business tomorrow, I will send out, with the help of HSCRC, because they have your accurate email list in a listserv, and I don't, they will get that out to all of you hopefully by the end of tomorrow. I'm not going to write anything then for a while, because what's going to happen is by no later than 2 weeks, if you want to do it sooner, that would be helpful, because then I could be feeding them. And as your input comes back to me, then our team, I'll take the lead on this, but we circulate drafts, and I get good comments from Donna and Alice Burton and my colleagues at HMA and so forth. So they all keep me going in the right direction. Then, as I get all those comments back, I will attempt to get a draft, assemble those, think about them, weave them together, and get a draft back to you in time that you have time to read it before the next meeting. Now, that's an ambitious timetable, because I'm going to get a lot. So that's what I'm going to try to do, if that makes sense to people. If I don't get 100% done, you know, maybe I'll get a 3/4 draft or something. You know, I don't know. I haven't really thought that all the way through. When the next meeting is April 21st? No, 18th.
April the
18th, yeah.
And it's going to be at Maryland Hospital Association.
Right, yeah. April 18th. So the timetable, thank you, Kim. Timetable's a little tight, but let me see what I can do. And then you'd be marking up a draft that includes all your suggestions. And then we'll have a discussion on that. Does that seem?
Yeah, I guess so. I think the process of drilling down is going to take more than one meeting. So I think really what I'm interested in is kind of polishing off Chapter 1 with the idea that, hey, you know, good job, we got Chapter 1, we got some comments, we need to polish off Chapter 1, and then we need to go on and work on Chapter 2, 3, 4, and 5 to complete the process. But you know, back to what Kevin is saying in terms of some additional areas that need more detail. But I do want to make sure that we're finishing off Chapter 1, because I think it does help us with an important baseline to help us along with the other chapters and communicating with other people.
So by Chapter 1, you mean the focus?
The high level. The high level vision, and with an acknowledgement that we need A, B, C, D, and E, and with whatever input came out of the discussion.
Okay.
I'll jump, because I think, Donna, if you're suggesting that this could stand alone and then we continue the work, is that?
Yes, as a first chapter, and acknowledging that more to come.
Because I think the group has said that they're uncomfortable doing that. I don't want to be the spokesperson here, but I think folks have said there's still too much left unsaid here, that we need at least one more opportunity, if not to take it to the next level. That this doesn't provide enough guidance, I would even argue, especially to a public audience, that makes it a Chapter 1, is at least what I heard, but I don't want to speak from.
Maybe react to that. I don't know if it's a Chapter 1. I mean, if what you meant, Donna, is it's at a high level, admittedly at a high level, and if it's represented as a high level and it's represented to be understood as just that, it's not necessarily Chapter 1. It's just the first cut
kind of version 1.
Version 1. I know. And then version 2, 3, whatever it takes, brings it to a greater level of detail. That mid-level, the way we described, is more, I think, the way the discussion went, and I think what you mean. It's not, there's a difference between saying this stands alone, this is done and stands alone, versus, and then more will follow, versus it's version 1 at a high level and we will continue to refine it to the point where we're comfortable with it. I think the meaning of the group was more the latter than the former.
Well, I would be uncomfortable. I would be uncomfortable circulating this version.
Yeah, no, we all agree on that. The version that you've been reading this past week is not ready for prime time.
That's what I thought. I'm sorry. That's what Donna, I thought I heard you say. You would like to be able to circulate this version as we work on the next version.
Yes, I would like to be able to circulate thoughts from this version as we work on the next iterations.
And for me, that makes me uncomfortable.
I think I would say the same. Representing the ideas within it is one thing. Sending it around as a product of the advisory council is another thing. I think we should say it's version 1 and we're working on version 2 to come. But before it's sent around, I think it needs more work. I think we're all set.
Yeah, I mean, I think this is the healthcare equivalent, Jack, with all respect to the work you put into it. This is the healthcare equivalent to saying we believe in apple pie and motherhood. I mean, and so what?
Yeah.
And a lot of bad things get done under the excuse that it's promoting apple pie and motherhood. So,
yeah, I hear you.
I think that's maybe a less elegant or polite way of saying what Carmela and Chet have been saying, but I certainly feel that way too.
Well, here's what I will do. It's my job to try to hear you out and give you what you need so that you can give the best advice to Donna and her colleagues. I leave it to others as to who shares what with whom at what time, which is sort of not my decision. But what I commit to all of you to do is follow this process, give you the follow-up guidance tomorrow, which will be very brief. Get your comments, task you with some homework over the next 2 weeks. Take all that input. Sorry, I just flunked Facilitator 101. And not the first time. So take all that, feed that back to you in the form of a revised draft as quickly and thoroughly as I can. It may be that it's 3/4 of the revised draft, just being honest. Whatever is feasible in the time constraint for the April 18th meeting. And then we'll have a specific discussion at that meeting, sort of chapter by chapter or section by section. Does that make sense to the group, Eric?
Well, I guess it would make sense if everything comes back and it's pretty consistent.
Yeah.
If, on the other hand, as I would anticipate, you're going to get some variation in terms of what people are giving you, things that may be in conflict with each other. What I would personally find helpful is if you would kind of stack those things up, and then we can debate those points and decide which direction does it go. I mean, there may be a series of things that lend themselves to incorporating straight back into the report as red line revisions, and it would be helpful, at least to me, if that's how you did it, so that we could actually see how that got kind of incorporated. But my guess is that there's going to be 5 issues or something like that where you get a group of people over here and you have another group of people over here, and we need to have that discussion and tease it out. Does that make sense?
Yeah, it does make sense. And I'm thinking the way I translate that into my to-do list is I may come up with a draft that says the following things as I take in all your comments there seems to be more or less a clear consensus on. And here they are. Outstanding issues where I'm hearing different things from different people include A, B, and C. And, I've received some things that point us this way and some things that point us that way. So that's on the table for resolution because I don't think we have a consensus on
That's not materially different from what you did the last time.
Is that right? Yeah. Okay. It's coming back to me a little bit, but yeah, I think you're right. I'd forgotten that. I can't remember what I did last time, but thank you.
Jack, can I just build
yeah.
on what Eric just said, because it touches more closely the spirit in which I offered the idea. The thought was to have real thought given to the issues and the topics that are the middle ground and the questions within each of the subject matters from each of us without a rush to groupthink.
Yeah.
In other words, to get that input before it goes to another version of the draft, but then to give us back an organized presentation of what came forth, to see the differences. I don't know that we see the differences now in the way everybody views it, or the commonalities. There may be more common thinking than we think. So if there's a structure, as Bruce and David had said, and others that you provide to it, Joe, but we all submit our thoughts and comments within that. You organize it and send it back. At least speaking for myself, I don't need to see another draft of the document. I want to see a discussion of the topics and the issues before there is another document. And write the document after we've had the benefit of the discussion.
Okay. How do others feel about that? Okay.
I think it would be better.
Yeah, probably would be. And yeah, thank you. Less midnight oil on my part, but I put it in. But I hear what you're saying, Chet, and that probably is a better iterative way to come to closure. So I'll do that. Okay. All right. Any other, before we move to public comment, we're actually more or less on time. Did anybody who hasn't said anything, or who has but has a final burning thought, this would be the time of the council members to bring it up? Carmela.
Can I just say thank you? You know, these are often processes that look like an amoeba, and I know it's hard, especially in your roles as leading this. Thank you for listening, and thank you for letting us continue to dig. Again, I think the good news is everybody around this table is engaged and anxious to contribute.
I appreciate that, and you're right, and that's what makes it fun. This is an engaged group. We have lots of ideas. It's hard to organize them, but, you know, and it takes 2 or 3 tries, usually. Howard.
Yeah, I'd just like to really echo what Carmela said. I think for me, it's a privilege to be witness to this process, to see people of goodwill who are powerful, influential, trying to solve what is a significant problem in healthcare. And I think part of it has been done already, and part of it yet needs to be done. And you know, I think Mr. Burrell commented on accountability. In terms of ultimate accountability, it is in fact the state, the Department of Health and Mental Hygiene, is responsible for the health and well-being of all the citizens in Maryland, and we all play each of the people around the table play an individual role in that, whether it be post-acute care, hospital care, or from commercial payers, or Medicaid, or whatever it is. And it's a matter of synthesizing now the last pieces of all of those pieces of the puzzle together to make this really a model for going forward in the country to solve what is really a national problem. So I don't look at it as at all trivial, and it's worth whatever effort we need to put in it. And again, I feel privileged to be here. So thank you.
Yeah, well, thank you. I can say, you know, when I discuss what I'm doing with colleagues around the country, you know, because we're also in this, it's very relevant to what both of you are saying. Is they go, wow, Maryland's tackling that? That's amazing. You know, there may be Oregon's approaching that, Vermont's now trying, but the list is pretty short. And people are amazed at the ambition of the undertaking. So I hear you. Okay, it's time now. If any of our guests would like to ask a question or offer a suggestion and comment, the floor is open to do that. Yeah, please, Mike.
Thank you, Jack. Mike Robbins with the Maryland Hospital Association.
One area that I know was clearly addressed in the original Advisory Council report, but I think we've neglected to reiterate in this report, which is important particularly as it relates to the area of focus, and that's the role of evaluation. We don't spend much time talking about what's working so that we can focus on just the things that are working and try to take off our plates the things that aren't working. So I think in thinking about additional comments here, we ought to particularly look at the role for the HSCRC or the state as a facilitator in sharing those kinds of evaluations, the programs that are working. If we have a PCMH programming that's working, what are the aspects of those models that were the reasons for success? Sharing that kind of information as part of an evaluation role is critical, I think, to the future success of this model. So I'd like to see some attention paid to some discussion about how we do evaluation on an ongoing basis in this model.
Great. Mike, that's an important point, and not only how we do it, but I take from your thoughts how we feed it into the policymaking process, that evaluation creates a learning curve and instead of just 5 separate studies around there, and it gets fed into the practice. So we put more resources ultimately into things that are working, which is an important point. Anyone else like to comment? Steve.
Can I borrow somebody's mic? I'm impressed by how hard you folks are working at this, and I'm really also very grateful, and I will presume to say on behalf of the Commission that you're doing us a real favor. The recommendations in the first report were quite helpful. For example, the recommendation to press ahead with getting people on global budgets was one of the reasons we did it, and it made a huge difference in terms of the sense of movement and accomplishment. That said, I want to get you thinking about the governance issue in a slightly different way. I think you could argue that one of the major problems with American healthcare has been that it has been easier to get money for hospitals than for other things that might be the things we're thinking about right now. And what we're trying to do is think about alternatives. Yet the Cost Review Commission has a statutory authority which ends sharply at the hospital doors. I mean, I can't tell you how sharply, but we were quite successfully sued on this subject when we tried to step a little bit beyond. So think about this as a kind of a basic challenge. You've got this group convened by the Cost Review Commission, whose authority is explicitly limited to hospitals trying to figure out how to reinvent healthcare in Maryland. Second, and closely related, is how little sense of real urgency is being deployed in the state of Maryland about this. And if somebody disagrees, they can do so. But here we have a project which is benefiting the state to the extent of about $2 billion a year. Usual federal horizon would be 10 years. That's $20 billion. That's not budget dust. And yet, I really do not hear people coming here and saying, this is really important. The governor thinks it's important. The secretary came, which is wonderful. But the same sense of urgency, we got to get something done, and we got to get everybody pitching in,
because this really matters. That's the second problem. The third problem is that so far there isn't any real state governance structure that's picking this up. And it's going to take legislation, I think. I can't imagine really succeeding in this without legislation. But maybe the council can, and that would be greatly helpful. But there has to be a way of doing this that really does bring the governmental input in a diverse and power-sharing way comparable to the diversity of the hospital engagement, the insurance engagement, and some public folks. So that's the third part. Now, we could go on that way. I think the staff of the commission has done an incredible job in getting this far without having things like new legislation and so on. But ultimately, a proposal to CMMI is a proposal from the state of Maryland, not just from the commission. That was made very clear to us with the last one. And so we need to think and we need advice, and I think your advice will be important in this issue. I, again, thank you for being willing to come here and think and push and say, no, maybe we should think about it a different way, because I think that's what will get us where we need to go next month. Next week would be better, but next month. Thank you.
Thank you, Dr. Jenks. Very helpful. Anyone else have a comment or a question? I think we're done. April 18th, Kim, at Carmela's home? At her house?
Your house.
Right.
Casserole provided.
Good. Thank you all.